It's not blinking.
Good
Oh, it's
morning.
also your screen.
Good morning, everyone. Welcome to
Morning.
Rounds. First presenter today, Dr. Jamie Miller.
Yes, everybody, welcome to our comparative ocular pathology round on this lovely morning on April 17th. Let's get started by advancing the slide. There we go. Just make sure it didn't register too many clicks. All right. So this first case here, I had to do a double check and make sure that this wasn't a cat, given its gross appearance. But this is a 4-year, 10-month-old male boxer dog with a history of a large eye for about 6 weeks. This is the left eye with severe episcleral swelling. They wanted to rule out neoplasia versus other for secondary glaucoma. They said the IOP was 40. They also mentioned that the dog has high globulins on blood work, so they are wondering about Ehrlichia, lymphoma, multiple myeloma, some other or those types of things that would cause high globulins. They did say that the CBC was normal. The other eye is also normal in this dog. So grossly, the globe is really ophthalmic. It was really big. We've got cornea up here at the top. That was pretty cloudy. We got this kind of opaque, high density material throughout the anterior chamber and the vitreous in the posterior chamber here. That's just completely filling the globe. And that is what we saw grossly. So let's see what histo shows. So being that this was a very big globe, it's on a very large slide. So here we can see, again, I've got an oriented cornea at the top. That opaque fluid is nice, solid hypereosinophilic material within the chambers. And here's our iris and ciliary body, and they're looking pretty hypercellular here. So we'll go take a look at that. Back towards the back of the eye, we didn't quite sample the optic nerve head completely, but we do have a little bit of the optic nerve. And then this is a little extra section that we usually include to try to evaluate for goniogenesis. But again, lots of blue stuff in the iris and ciliary body. So let's head up there. And our slide comes with blue dots, so you know there must be something very interesting on this slide. Here's our cornea right at the front here. And we can see the cellular infiltrate is expanding and effacing the iris, heading back into the ciliary body. And as we go around the back of the globe, kind of extends out through the sclera and the episcleral tissue. We'll keep going back around in this direction. It's kind of quiet towards the back of the eye a little bit. And then we can pick back up our ciliary body. And then there's this little sort of divot here, kind of right at the limbus. Let's see, here's our cornea here. We'd be heading into our limbal sclera here. And you can see it's got this lovely little defect, and the uveal tract is kind of bulging out into here. So there's a little bit of a limbal scleral rupture. So I'm gonna head back over here. And if we take a closer look at what these cell types are. It's very dark. Oh, look at that. I didn't even have to go to my blue dot. So we have a large population of macrophages and neutrophils. This is very dark. Why is it so dark? And we realize that it's probably quite dark for you guys, so hold on a minute while we figure out.
Is exposure, so yeah, did they end up change it to,
We did some stuff when we first got on.
hold on, hit escape for me? Thank you. I always do this as auto.
Okay.
That should be better.
All right, oh, there we go. Now,
Yeah.
hopefully you can see the cells a lot better.
If we're showing a brown tumor,
Brown tumor.
do manual.
Okay.
But if it's anything else,
All right, awesome. So lots of macrophages, lots of neutrophils, lots of plasma cells, little lymphocytes, some of these smaller guys in here. And as we cruise around, we start to see these organisms here, these little yeast organisms that are a little bit larger, maybe 50 or 80 microns in diameter, kind of have this basophilic stippling in the center. I tried to look in there, too short. And head back towards my blue dot. So I found at least one that has a particular feature for this organism. So again, got a nice little spherular here. And then in this one, get a bit closer here. Go. We got a nice little double contour wall here, and all inside are these little endospores. So this organism is doing endosporulation, which is a feature of this organism, which is Coccidioides species. And so as we cruise around the rest of the globe, I'm gonna head back over to the side where it was a little ruptured. And we're going to see, again, very big globe. All right, here we go. Kind of right near the limbus here, we have a break in Descemet's membrane, kind of stops abruptly here. And we have this nice fibroplasia where it is broken. It does blend with a fibrovascular membrane on the anterior surface of the iris, so causing some synechiation. And then this inflammation again extends through the limbal sclera, and then there's kind of prolapse of the uveal tissue. The eosinophilic proteinaceous material was present in all chambers of the globe, so it's a high protein exudate. And then, like I said, the back of the globe was a little quieter. The retina is detached. There is a little bit of a mild lymphoplasmacytic infiltrate into the retina, probably not too surprising given how inflamed the rest of the uvea is. And the optic nerve wasn't too bad. So the organisms here, again, consistent with Coccidioides. So it was a severe pyogranulomatous endophthalmitis, uveitis with scleritis. Again, that limboscleral rupture with uveal prolapse. Those intralesional yeast and intraocular yeast with the endosporulation and the size are most consistent with Coccidioides species. The high protein exudate was a little unusual maybe. It was present in the blood vessels as well in the choroid, so we presume that it's from the hyperglobulinemia that they reported clinically. And I did a little digging and I found a paper from 2003 in JAVMA on the clinical pathologic and radiographic findings of dogs with Coccidioides. And in 8 of their 15 cases, hyperglobulinemia was reported.
Cool.
So that was pretty cool to kind of put that together a little bit. Again, with the caveat that they should clinically also look for any other causes for hyperglobulinemia. Coccidioides can also cause mild anemia, increased neutrophils and monocytes, and low albumin. So they did say the CBC was normal, but just kind of a interesting case with a high protein fluid.
Yeah, we often see that high protein fluid we associate with hyperviscosity syndrome, but it didn't look like there were any vascular.
Mm-mm.
Well, it's a very suppurative and necrotizing exudate, right? But it didn't look like there were any vascular problems or any areas of ischemic necrosis anywhere. But that's good to know. Didn't necessarily associated coccidioides with, we know that rather than multiple myelomas and neoplasia, other infectious processes can cause
Mhm.
hyperviscosity syndrome, with coccidioides was on my list. Now it is.
Awesome. All right. So next up, I've got a Laysan Teal Duck. I think that might be how you present it or pronounce it. This is a older than 10-year-old female duck from a captive facility. This duck actually already had its other eye enucleated back in 2021 and sent to us. It had similar lesions to what I'm going to show. So we'll just focus on the current eye. So this is the left eye that has a history of recurrent corneal superficial ulcers with potentially recent vascularization or epithelialization over the cornea. They were kind of questioning that. They said that the duck appeared non-visual with no improvement with topical and systemic anti-inflammatories and antibiotic treatment. IOP was 26. They said unknown to glaucoma. And otherwise, the duck had hatched ducklings back in 2021 and apparently has had a reducible coelomic hernia for a while, since I think that was reported on the initial eye that we got as well, but no other known issues. So this is our gross section from our duck. We did have to decalcify it briefly because of the scleroscopes, but we were able to see that the cornea was pretty opaque, and otherwise maybe a little thickened here, but not a whole lot else going on. Let's see, I decided that I liked this one. So let's do, all right. So, oh, here, let me give you a separate first. Ooh. Let's get that on. All right. So here is our duck eye. There's a little bit of material here in the anterior chamber that we'll take a look at. A little bit of cellularity, maybe in slightly increased thickness here to the iris leaflets, but otherwise fairly quiet in the rest of the eye. All right. So if we take a look at the cornea here, the epithelium is a little bit hyperplastic, starting to keratinize, and we can see that there are a lot of blood vessels going on here. Let's see if we get a little bit closer to this. There's a few heterophils in here, a couple of lymphocytes, plasma cells, so a keratitis, and some fibrosis and vascularization. That was pretty consistent throughout the entire cornea. And then what we were noticing is that the iris leaflets were kind of expanded by this extracellular smudgy eosinophilic material. There's a little indescript here. And the other interesting thing that we found is in the limbus, it was associated with these macrophages and large multinucleated giant cells. So in birds, you always have to have mycobacterium on your list. I will say we did do an acid fast and it was negative. But apparently you can see these with this condition. And since we already had the other eye, we had a pretty strong suspicion of what it was already. There is a pretty robust fibrovascular membrane that kind of runs retrocorneal, sort of pre-irital. It causes some wrinkling of Descemet's membrane. I think the lens was okay, or maybe had some very mild cataractus change. But the rest of the globe, retina was pretty quiet, optic nerve. We didn't quite get the pectin in this section, but it looked pretty good. So when we have extracellular smudgy eosinophilic material like that, we always often think about amyloid. So we did a Congo red, which should have a nice sort of brick red staining to that extracellular material. And here it is. And we can see that it's also here in the limbus and associated with the macrophages as well. And I'm going to try to polarize it for you, because the other awesome feature with Congo red and amyloid is that it should show a nice apple green birefringence.
Yeah, in the back.
Okay. Let's see if I can get this. See if it's gonna, there you go. Apple green. Ooh and ah, ooh and ah. So cool. So again, this was something that we saw in the original eye back in 2021. We did not see the multinucleated cells in the original eye. But
Were they phagocytizing amyloid?
I think so. Or they were at least pretty closely associated with the amyloid material. Didn't see them anywhere else in the eye, no other.
Cool.
And sorry, the section was a little uneven, so it's a little hard to focus. No amyloid in the cornea. Maybe a little bit at the periphery here, but the rest of it was pretty quiet, pretty uveal,
Yeah,
limbal.
that's the impressive part of it. It's very uveal centric.
Yes.
Did it have a reason for like chronic inflammation, like dermatitis, or?
Not that we are aware of. So yeah.
I don't know if you guys heard the question. The question was there a reason for chronic inflammation on the history, or even in the eye? It didn't look like there was a lot of inflammation.
Yeah. So yeah, with amyloidosis, it's usually a systemic inflammation that leads to deposition of the amyloid, either pododermatitis or bumblefoot. We often see it in like livers and such. I did find a paper where systemic amyloidosis in some laying Japanese quail had these multinucleated cells associated with it. It's something I either didn't know or forgot that is potentially seen in avian cases with amyloid, that you can get the multinucleated cells, but you should also rule out mycobacterium as well, because the Joint Pathology Center has a case online that is both amyloid and mycobacterium positive. So good thing to rule out. And we basically said we weren't sure if the duck was still alive since we have both of the eyes. It wasn't indicated. I wasn't sure with it being in a captive facility if it is now someone's lap duck or if it's no longer with us, but that they should correlate with any potential other clinical findings, although they didn't mention anything in their history. So
Maria Schenk said here on the comments that she often sees multinucleated giant cells as a foreign body reaction to amyloid and plasma cell tumors.
cool. Awesome.
And Elisa said she shared with Maria and Kara a horse with the conjunctival amyloidosis, presumed AA amyloid. Cool.
Awesome. Cool. All right. And now I will turn it over maybe to the next presenter. Megan.
Oh, sorry, you know what, I don't know. Clearly don't know what we're doing.
We'll get it sorted. Okay. So we'll start with this case of a 14-month-old spayed female husky. They describe so marked episcleral injection and inflammation, lowish IOP at 13 millimeter mercury, fluorescein stain negative. And then later on, let's see, the episcleral tissue started to appear thickened and raised. Cloudy cornea, can't see inside the eye. Basically, those are the key historical details. So let's take a look at the gross presentation. So we have cornea up here, although its demarcation is kind of unclear to some extent. And we have iris leaflets here and here, and the lens should be here in the posterior chamber. We have this big white structure here sitting in anterior chamber and almost kind of blending into cornea, at least based on what we can see grossly, which may be lens, you know, and spoiler alerts, it is lens, but so there's that. And then the iris leaflets are covered in a white tan substance. We also have retinal detachment. Maybe the retina looks a little bit more thickened and opaque than it usually is, and the vitreous is a little bit cloudy. So some nice gross features. And we'll take a look at, will we take a look at it? I want to
Yes. Escape.
forward it. I did do
Escape.
I did do escape. Uh-oh. Is it frozen? And show. That worked. Okay, yes, we're still good. Everything's fine. The IT is running smoothly. So it's kind of tough to fit this one on a
Try the other one.
subgross. Yeah, even closer.
Yeah, because it doesn't matter. You can go the other one because it will. So
It's a big eye. It's hard to get it to fit in a subgross. So we've got cornea up here. We've got this eosinophilic stuff, which will be lens when we look closer, but it's hard to say because it's so distorted from low mag or from subgross. The anterior uvea is looking rather basophilic. We have our cloudy vitreous with a little bit of blood in it and our detached retina. Cornea is now facing to the right. And let me confirm for you that this is lens. So we have, oh, sorry, I just batted the microphone. We have more guiding globules here. We have liquefied lens protein. We have some remnant fibers. Everything's sort of fragmented, surrounded by inflammatory cells. Here's a nice end of some of the fibers. It looks like lens fibers. A little bit better here for you. And as we could see, next to these fibers just sort of floating in the anterior chamber, we have a piece of lens capsule, sort of fragmented, and we've got inflammatory cells tunneling into the capsular ends. It's actually kind of like some of the lens has remained in posterior chamber. So here's iris leaflets, and here's like part of the lens right behind iris leaflets, but then the anterior lens capsule is ruptured and basically extruded most of the lens into the anterior chamber. That's part of why the appearance is sort of weird. Can confirm our uveitis and a prurital fibrovascular membrane. And also that this patient has a blue eye. So there's not many stromal melanocytes in this iris stroma. It's mostly lymphocytes and plasma cells. And we have a epiphyme from here to here, prurital fibrovascular membrane.
So we definitely have a lens capsule rupture and inflammation in and around the lens and in the anterior uvea. And if we look near the posterior lens capsule, we see tons of bacteria. So this is an inflammation in and around the lens with intralenticular bacteria, a lens capsule rupture, a hypermature cataract. And with this presentation, we would typically diagnose a septic implantation syndrome. So this is thought to be due to a contaminated penetrating trauma, most typically a cat claw. Nature's cataract surgeons, they just need to work on their aseptic technique. The penetrating trauma introduces bacteria into the lens, and the idea is that it may brew in there for some time and then eventually erupt forth and create a endophthalmitis and phakitis, and the endophthalmitis will typically center around the lens. There can be a variable amount of time between the initial trauma and the ultimate eruption with endophthalmitis. They can go for quite some time between. So we don't always see active evidence of the site of penetration in the front of the eye by the time we get the eye enucleated. And an initial penetrating trauma is not always described, but it's often quite satisfying when we diagnose a case of septic implantation. And then they come back and say, oh yeah, the dog was in an altercation with a cat some time ago. So that's septic implantation. It's not normal, but
The question was the cornea normal?
so there's a keratitis and there's vessels in here and some stromal hemorrhage and things like that. There isn't any overt sites of penetrating trauma in the cornea. There's a little bit, yeah, there's this. Well, okay, never mind, I lied.
It's beautiful.
Clearly someone needs to review their cases before rounds a little bit more closely. So anyway, there's this rupture in decimase with curling of the end, which implies that it was probably a traumatic rupture, as well as this robust fibrous reaction at the site. This may have been the original site of penetration through the cornea. There you go.
Yeah. You only need a cat claw stuck in there.
Yeah.
Which has happened before,
Right.
or at least the sheep.
Yeah, I was going to mention that's the only, since there's usually a time gap between the trauma and the unresponsive endophthalmitis and glaucoma, that is usually the type of lesion that we see, just a remnant of, a penetrating lesion with a break in descemes membrane, which is the most easily identifiable. Once the descemes membrane will not heal per se, and fibrosis around it. So that was a complete case with, we found a bacteria in the lens and the rupture in the cornea.
Indeed. Yeah, good question about the cornea. There you go, main diagnosis. There were a couple others as well. And if there aren't any further questions or comments, we'll do the next case. Next case is a 13-year, 3-month-old neutered male domestic short-haired cat. This cat was presenting with very severe chemosis in the left eye. Very difficult to see the actual glow. Oh, I should move on to the gross image. There we go. Severe chemosis in the eye. Very difficult to see the globe itself, they say. And this cat also has a history of FIV and urinary obstruction. So a couple other things that are ultimately probably unrelated to the eye. So we have our eye here, and the outline of the eye itself is mostly here. So this is where eye sort of used to exist in its own space. We can see that their lids are still on this globe and they're stretched over this huge area of tan white swelling, which blends into the sclera. It's in the episclera, it's in the orbital connective tissue. This thickened tissue here is choroid and ciliary body, so probably ciliary body roughly here, extending into choroid back here. And the back of the sclera is actually missing and was not with the globe in the jar, at least. So presumably all the tissue back here was extremely distorted. On gross exam, I actually did the gross exam for this case as well. It was even difficult to identify what was going on in the back because of this abnormal tissue when I had it in my hands and could turn it round and around grossly. The intraocular chambers are also filled with a similar abnormal tan tissue. The cornea is also very thickened and just blends directly into this tissue. So there's no clear evidence of a lens grossly. That's another thing to point out. At least grossly, lens is not very well identifiable. All right, let's see if escape key works. Escape key worked that time. Okay. I'm not going to try it for a subgross. Well, we could probably try. It's a rather large slide, though. Let's see. Let's try. At least we'll try. It's going to be hard to fit a significant amount on this slide, regardless, is the thing. So here's our thin eyelids stretched over that globe. You can see that that abnormal tissue, which was white tan, grossly is very basophilic histologically, implying that there are tons and tons of cells here. Here's that big bump as we scan around. Where the eye kind of is, you can make out, for example, on this side, some ciliary body plique, but most things are very distorted and hard to make out. You do have this little swiggle of eosinophilic material, which is interesting, and we'll look at that closer. All right. Let's see. This. Flip it around. We may have flipped it around. We flipped it around. Hold, please. For the sake of orientation, I like to try and do it the same way each time. All right, again, orienting you, we're here in the anterior globe with these very stretched out eyelids over the surface of this markedly enlarged globe. Let's go through all this tissue in the outer layers of the eye and make our way slowly towards the middle. Before we keep going though, so here's where we can kind of make out where cornea used to be. So we have these fragments of basement membrane, which is most likely Descemet's membrane at this level. And it's multifocally fragmented and distorted by this cellular tissue, but we can see sort of roughly where cornea should end. Hard to tell, everything's very distorted. Let's see, here we go. And here's that, well, let's see. And make sure I don't say something silly again. Here is that eosinophilic squiggle that we saw from low magnification. I was like, that was still Descemet's membrane. Yes, it was. That was still Descemet's membrane up there. Here is the eosinophilic squiggle inside the eye. And we'll sort of start there and migrate our way out. So this eosinophilic squiggle is distinct from where we were up by the cornea, and it's much thicker. So this is much more consistent with lens capsule. So we see that there is a lens capsule here still, and why it was so hard to make it out grossly, it's basically just capsule, and I don't see any recognizable lens fibers anymore. It's ruptured, therefore, in particular because these ends are embedded in fibrous tissue and frankly, neoplastic tissue, we can stop being so cagey about it. And an interesting feature of this case is that next to the lens capsule itself, most of this tissue here is just collagen with dropout of the cells that were once here. As we go away from the lens capsule, that's when we start to see more of this viable neoplastic cell, these viable neoplastic cells. And if we drop down into a field of these cells, we're going to decide that we don't like this field and want a different one. Yes, we are. Let's see. Let me find you a good one. I think the stuff in the orbital tissue might be easier to see. Here we go. We're going to drop down and we're going to sit here instead of slowly migrating around, as is my want. So what? Go higher. We're going to go higher as well. It's as if there's an angel sitting on my shoulder whispering in my ear. So here we are looking closely at these neoplastic cells. These cells are spindle-ish to polygonal. They're rather pleomorphic. There can be 1 to 2 distinct nucleoli. Here's 2, here's 1. The chromatin pattern is quite coarsely clumped to fasciculates. These are some very active and angry-looking neoplastic cells. The borders are typically indistinct. There are some areas where they look more spindle-shaped than others. Now we will migrate around. Let's see. Here's an area where they're a little bit more spindle-shaped and interdigitating with some collagen. Although this could be them basically dissecting through the scleral collagen. It's hard to make out where the normal structures of the eyes should be in this case. So here's another field showing the same thing. And so we have a tumor that has a pretty variable morphology, but is ultimately fairly spindle shaped. It centers, there's a necrotic area that's centered around the lens, and it becomes more viable the further away it gets. Drop down one more time. You probably see something fairly similar. And so this is most consistent with a post-traumatic sarcoma spindle cell variant in a cat. And this is quite an extensive one that is extended through the sclera into the episclera. It's in the cornea, it's in the orbital muscle. It is throughout the uveal tract and basically filling all intraocular chambers. It is essentially completely consumed this globe. There are some areas of osseous metaplasia, particularly near the lens. So in case you were curious about that, we can take a brief moment to drop in on that. Osseous metaplasia. And an interesting feature of this case is if we go back here where there's the choroid, you can see that the choroid basically ends in just straight neoplastic tissue. And if we look at what's left of the choroid embedded in these neoplastic cells, oh, see, here's a nice area where they look very spindly for you. There you go. We can see that there are these oval-shaped sections of, these neoplastic cells. And you can even see them kind of tracking into the smaller vessels more further into the choroid and maybe into the tapetum, or what once was tapetum. It can't really make out tapetocytes anymore. So this is highly suggestive of vascular invasion of these neoplastic cells as well, although it's hard to make out the vessel walls as well. So there have been some reports of post-traumatic sarcoma metastasizing. It's not necessarily a common feature of the condition. The prognostic feature that is much more important is whether it extends past the sclera and into the episclera or into the optic nerve, which is the feature that most predicts whether it'll migrate back along the optic nerve and towards the brain, as you might imagine. So that local aggression or local invasion and tissue destruction and difficulty in excising the whole thing is more commonly the issue with prognosis. In this case, there is also the suggestion of vascular invasion, and you would wonder if potentially this one maybe has at least a suggestion that it has more of a metastatic potential, but you can't confirm that metastasis has occurred with this. So that's just an interesting feature of this case that we don't always see. And that's post-traumatic sarcoma, spindle cell variant. Presumably this cat had some sort of traumatic event that ruptured the lens at some point previous in life. And then this neoplasm arose from lens epithelium. 13 years and 3 months. They say duration of problem about a month.
Very unlikely.
There were some skeptical noises.
Like 7 years.
Yeah.
It's possible that the tumor sort of had an explosive growth more recently, but certainly it would be a guess that there may have been something going on in this eye a little bit longer than that. Sometimes these eyes do present with a history kind of like that, where the eye has been vesical for a long, long time. And then they say, you know, first it was small and now it's huge. Like basically it erupts and becomes quite ophthalmic as the tumor suddenly explodes in growth. So not necessarily an uncommon history.
Yeah, we often don't know when the trauma happens, but when the ones we received a timeline of the traumatic history can range from months to 10 years. You know, so its tumor certainly can take its time to develop.
Could you talk about our study that we're trying?
Oh, yes, plug. So there is a study currently going on feline ocular post-traumatic sarcoma, where we are trying to procure fresh frozen tissue from these cases that may be suspected post-traumatic sarcomas clinically. And the idea is to do some genetic testing on these cases, and we need the fresh frozen tissue for that. So what we are asking is for cases that are suspected of post-traumatic sarcoma to submit part of the sample as formalin fixed for routine diagnostics, and part of the sample is fresh frozen for some of the more special testing. And the draw for this is any clinicians who may be listening, if you participate in this study, we will give the histologic diagnosis and the reports for free on these cases.
And if you have a suspected case, please get in touch a couple of days to a week before enucleation is scheduled, so we can get the materials sent to you.
Yes, we'll send, there's an SOP for instructions on how to collect material, like equipment for how to collect, and there are instructions for how best to ship it so that it arrives in a good status for use in the study. So if you have a suspected case, please get in touch earlier than later, and we'll chat about it and make sure that it runs smoothly.
Chelsea asked here in the comments if we need neoplasia or skeletal muscle fresh. We would love neoplasia
Neoplasia.
or neoplastic tissue. Of course, we cannot completely make sure we're sampling it, but if we go after something, there'll be the tumor.
Mhm.
Alrighty. Next case might look pretty boring grossly, but it's pretty exciting histologically. This is an eye from a 2-year-old Labrador Retriever, neutered male. The history we got was fairly brief. And it is that this was a ophthalmic globe that had glaucoma. There was no overt uveitis. The other eye had an open iridocorneal angle. They said for this affected eye, there was minimal improvement with aggressive medical therapy, latanoprost, dorzolamide, and demicarium bromide. The IOP was 51. Duration of problem was 3 months. So we got the eye and thought it was pretty darn boring, to the point that we didn't take a picture when we first grossed the case. And I don't remember which one of us it was probably me. But anyway, but after the fact, after I got the slide, I went, oh my gosh. And I went back and pulled the second half and took a picture of it. So basically there's not a whole lot to see here grossly. And this is the half without the optic nerve head. So that's why we don't see the optic nerve head back here. In retrospect, perhaps if you stared a little bit, you might see that the ciliary body on this side of the globe, which is ventral, has a little bit of a thickening and it's kind of pale tan. And maybe the iris itself over here is a little bit thick and a little bit tan. And then maybe right here, oh, well, no, actually, forget that. But the other thing to notice here is that there is a decent amount of pigment in this eye. So this, maybe the iris is looking a little bit golden, but the pigment in the back of the eye looks pretty consistent with a brown eye. But we will get there because that's important. All right. Maybe similar to the gross image, the subgross is equally as boring. In this image, you might notice that the ciliary cleft is not very apparent and the meshwork seems to be pretty collapsed. So there's something going on there, but other than that, it looks pretty boring. This other side is a little bit more interesting in that the iris and ciliary body are slightly expanded. They're slightly more basophilic than you might expect, which usually indicates that they're hypercellular. And also from this magnification, you can appreciate that the limbal sclera right here is a little bit thinner than it should be. So this is consistent with ophthalmos. Also, the end of Descemet's is probably up here somewhere, and the base of the iris is all the way down here. So there is at least some degree of iridocorneal angle recession. And also when you look at the first ciliary body plique, they appear to be sort of coming off what kind of looks like the back of the iris. So there's a little bit of distortion of the anterior uvea in this area. The lens itself is pretty boring. And then back here, I can't remember the specifics, but we'll look a little bit higher mag. At least from this magnification, it doesn't really look like the optic nerve head is cupped in this plane of section. Here's our extragonio slice where you can actually see similar expansion and distortion of the iris and the ciliary body. And here it's even more pronounced because the ciliary body plica are coming off the back of the iris. So this is a dog that's trying to pretend to be a rabbit. That's normal for rabbits, but not dogs. All right. Let's find our slide. There we go. We're going to start in the gonio slice, actually. So as we look at the gonioslice, as I said, so it's hypercellular, so it's a little bit more basophilic than it should be. But another thing to look at is actually how much pigment there is in this eye. So there's a decent amount of pigment in this iris stroma. So it really does appear to be a brown eye. You might be wondering why I keep talking about the color of the eye. Well, when we look at what's going on here, we have an interesting population of spindle cells that are kind of doing swirly whirly things. And as we look around, it's a similar pattern throughout. I like this area right here. So we'll go a little higher and a little higher again. Oops. So we have spindle cells that have indistinct cell borders. They have some vacuolated to fibrillar amphiphilic cytoplasm and elongated nuclei that are kind of bland. The chromatin pattern is kind of homogeneous, and they have mostly indistinct nucleoli. There are mitotic figures scattered around. When I did the official count, I counted 5 in 10 high-powered fields, 2.37 millimeters squared. But I really liked this pattern right here that it was kind of forming right there. So this is very strongly suggestive of the patterns that we see in peripheral nerve sheath tumors. I can never remember if this is Antony A or Antony B, or if this is some other structure who's, a Verroquet body, a Verroquet body. So this is a beautiful, this is a beautiful example of a peripheral nerve sheath tumor or a schwannoma type tumor in the iris of a dog. So the interesting thing about this is that this is a brown eye, and we see this type of tumor in blue eyes almost exclusively. I'm sure we've definitely reported one previous case in a brown eye in the past, probably about 7-8 years ago. And I'm sure we've probably seen a couple here and there, but so this is another one to add to our short list of what we believe is a schwannoma and a brown eye. One differential for this would be a melanoma or melanocytic neoplasm of some sort. You can never really rule them out unless you do extensive immunohistochemistry. I basically said that the prognosis for the two differentials, either the schwannoma or PNST kind of thing, and a melanoma or a melanocytic tumor are essentially the same. I did count 5 mitotic figures, which really would bump this up to like a malignant uveal melanoma. But even malignant uveal melanomas in dogs very, very rarely metastasize. So really the prognosis is fairly similar. Schwannomas in blue-eyed dogs can metastasize, but very rarely. So once again, a fairly similar metastatic potential for this, for my 2 top differentials. I saw there was something in the comments. Is there someone want to comment? Is there something to be said? We'll go back and look at.
Any chance this is a metastatic peripheral nerve sheath tumor? To the eye, I assume.
So given the fact that it is primarily in the iris and ciliary body stroma, I would assume that this is a primary uveal neoplasm. It is on the surface of the iris a little bit, which is actually fairly common for schwannomas in blue eyes as well. They tend to do stuff on the surfaces of the iris, as well. So I wouldn't take this quote unquote carpeting to be a metastatic lesion. So in my opinion, because it is primarily in the iris and uveal ciliary body stroma, this is most likely going to be a primary uveal neoplasm. This is also a 2-year-old dog, which is a little bit young, I think, even for most schwannomas that we see. As a quick reminder, Labradors are actually overrepresented in the population of dogs that will develop melanocytic tumors at a young age. So maybe this is just a really unlucky lab. So back to the question of glaucoma. I believe I probably concluded that this was glaucoma as per history, not confirmed histologically. In this image of in this area of the retina, you can see there are plenty of retinal ganglion cells present. And we did not sample the optic nerve head very well. On this side of the eye, which is probably the ventral side, there maybe are slightly fewer retinal ganglion cells. I don't remember what exactly I said about glaucoma. Let's see here. I said, as per history, not confirmed histologically. So,
Questions here for you.
okay, questions.
Elisa wants to know if we call it straight up schwannoma or uveitis to exclude polypigmented melanoma right off the bat.
I called it an anterior uveal, poorly differentiated mesenchymal neoplasm with clean margins, and I said a DDX of uveal schwannoma in a brown eye, more likely based on morphology, versus a malignant melanoma, which I thought was less likely. I suggested we could do GFAP to see if the cells express it, because the uveal schwannomas that we typically see, at least some of the cells in the tumors will express GFAP. Once again, I basically concluded that the prognosis was very similar between the two, so I didn't feel that it was actually that clinically necessary to do IHC. They have not requested that we follow up with GFAP staining.
Yeah, so Elisa was saying specifically in a blue-eyed dog, not in this case because it's pigmented. Yeah, if it's a blue-eyed dog, like a classic husky, I think we wouldn't necessarily entertain a melanoma that much.
Yes.
Right, depending on the case, but they're most characteristic.
So you have to be, so I can't remember the specifics, so forgive me. You have to be a little bit careful with melanocytic neoplasms and schwannomas, especially when using the melanoma cocktail, which is a mix of 4 different antibodies. So if any of those are positive, then it's read out as a likely melanocytic neoplasm. And I can't remember, there might be some random weird crossover between, for example, melon A and the cells of a PNST. And therefore, you can't necessarily use the melanoma cocktail or even a single melon A to differentiate between a schwannoma and a melanocytic neoplasm. That might be why I didn't suggest doing a melanoma cocktail or a melon A and suggested a GFAP instead, because as far as I know, melanocytic neoplasms should not express GFAP. Of course, immunoconfusion never ceases to amaze us. So
and Ryan was asking, does it have the classic entropion that we see?
that was a good question, Ryan.
That's what it was trying to see grossly.
Yeah, that's what I kind of was trying to see grossly. It didn't really, actually, I'm not sure we're sampling the tip of that iris.
That is.
So in schwannomas of blue-eyed dogs, we typically, one of the more consistent, interesting features is a pronounced ectropion UVA, for lack of better term. But basically the iris epithelium gets pulled around to the front of the iris. Sometimes it's so dramatic that clinicians will report an eye color change from blue to brown because that pigmented iris epithelium is pulled all the way around. In this case, it's pretty wimpy, at least in this section. And grossly, I couldn't quite tell. That's why I paused, but I was like, ah. And then I vaguely remembered that it wasn't very prominent in this one. So I thought that was also kind of an interesting feature of this one. Good question. Okay. Any more questions, comments?
We're good here.
Yes.
Why is it more common in blue-eyed dogs?
Good question. We do not know the answer to that.
Dr. D has some theories about so if you do a GFAP on a blue eye iris, on a dog with a blue eye iris versus a brown eye iris, the blue eye dogs, they appear to have GFAP positivity on the surface of the iris. And I think that the explanation is that they tend to have differences in their how their peripheral nerves are surrounded by Schwann type cells. But why brown eyes don't have that, we don't know. And I think it's just a matter of anatomically having those cells there for blue-eyed dogs and then becoming neoplastic.
Okay, so there you go. Kind of an interesting case. All right, I got 5 minutes for the last one. Here it is. It is the globe from a 12-year-old male intact male poodle. The history we got was pretty brief. History of thesis bulbi in the left eye with recurrent infections and current concern for endophthalmitis. So we got this eye. We said it was kind of small, so I guess we would agree with the thesis bulbi. And actually it is pretty small. This is a 1 centimeter marker. So yeah, kind of small dog, a small eye even for a poodle. However, when we cut into it, there's not a whole lot left that's identifiably eye-like in this eye. So the cornea is always at the top. So basically tan brown tissue fills this globe. Some of it's a little bit red, so it's probably poorly fixed, and that's an area of hemorrhage. There is also this yellow structure here that's a little bit irregularly shaped. This is actually the lens. So basically there's a giant tumor in this eye. Let's just go right to that, especially with limited time. And we're gonna go right to, well, I so gross. Oh, thank you. That's always important, isn't it? I suppose that is important.
For while you set it up, Kelsey sent a little bit about the PNST and IHCs that the melanoma cocktail is actually less likely to label spindle cell variant of melanoma and should label soft tissue sarcomas, including PNST. The recent problem is that SOX10, which labels melanoma, might label PNST as well. Melanoma cocktail has 100% specificity and 94% sensitivity. So SOX10 might be the most problematic with labeling both.
Got it. Thank you, Kelsey.
Thanks, Kelsey.
All right. Okay, so here's our globe. That's the lens that I landed on right there. This is the optic nerve right there. There's some scratches on the cover slip, unfortunately. So here's the cornea up here. There's some artifact in that cornea stroma. That's a mounting medium artifact. And then basically the globe is filled with, all of it is, all of the uveal tissue is effaced by a neoplasm. All of the pink areas are necrotic. There's some hemorrhage in their necrotic areas. Here is the lens looking pretty sad at this point. And we're actually going to go down at higher mag in this area because it's the most well preserved. So once again, there's our optic nerve. Here is tumor that was viable at the time of fixation. The cells are forming maybe some interlacing bundles and streams. And here and there, you might start to pick up a little bit of pigment in the cells. There might be some right there, might be some right there. So the cells themselves are mostly spindle shaped with indistinct cell borders. They have some vacuolated to fibrillar, maybe amphiphilic cytoplasm, and oval to elongated nuclei with some finely clumped chromatin and single prominent nucleoli. As I said, even from, and now that we're at higher mag, you can start to pick up a little bit of dusting of pigment in many of these cells. So this is consistent with a malignant melanoma. The mitotic count was 18 mitotic figures, so definitely bumps it up to a malignant one. As I said before, even malignant uveal melanomas in dogs tend not to metastasize, and it's something like 2 to 5% of them will actually lead to metastatic disease. We got no indication that this dog has any suggestion of systemic disease to suggest metastatic disease. The rest of the globe, let's take a quick tour. The lens itself, the lens capsule is wrinkled. There is deposition of collagen inside the lens capsule, so that's consistent with previous fibrous metaplasia of the lens epithelium. That's one of the hallmarks of cataractus degeneration. We also have mineral. All this dark purple stuff is mineral. And then here and there inside this lens capsule, there are a few macrophages consistent with lens capsule rupture, which I didn't actually find this site of rupture. Maybe like Megan's Decimase membrane rupture, I will find it now. But I didn't actually find it when I was looking at the report, or sorry, looking at the case for the report. Oh, here we go. Here's a bunch of macrophages with some cholesterol crystals. So I assumed that there was lens capsule rupture that I was not able to identify in this plane of section. So a very advanced, long-standing cataract. I don't necessarily think that there's a strong connection between the formation of the tumor and this advanced cataract. The corneal epithelium is hyperplastic, mildly keratinized. The stroma is strongly vascular, robustly vascularized and fibrotic. There is at least one break in Decimase membrane. You can see it right here. There's one blunt end right there. So at least one, probably Hobstria. Although they said thesis bulbi, maybe trauma was part of this
Mhm,
dog's
yeah.
past, and it may have been trauma to a blind eye after it had already developed this tumor. And presumably there was glaucoma at some point in the past. So that's all we got. That's a nice example of a very extensive uveal melanoma, malignant melanoma. And as I said, the prognosis for these is actually pretty good, as long as there are clean margins, and I believe they were clean in this case. And that's about all. So thanks for joining us in rounds today. Any questions about this
No,
case?
that's-
Okay. All right. Thanks, everyone.